Okay, good afternoon, everyone. I think we'll go ahead and get started. I'd like to welcome everyone to our Mayo Clinic Health System Let's Connect webinar on the COVID-19 vaccination myths and facts. My name is Dr. James Hebl. I have the privilege of serving as the Regional Vice President for Mayo Clinic Health System across our southwestern Minnesota region. And with me today is Dr. Eric Gomez, who I'll introduce more formally in just a moment, as well as my administrative partner, Mr. Terry Brandt, who serves as the Regional Chair of Administration for the region as well. So the purpose of today's webinar is to provide a broad overview of the COVID-19 vaccine, including how the vaccine is made, many of the myths that are floating around out there. Our goal is to debunk many of those myths, as well as to share with you some of the top questions that we're receiving from our patients as well. As I mentioned, with us today, we have the privilege of hosting Dr. Eric Gomez. Dr. Gomez is Assistant Professor of Medicine within the Mayo Clinic College of Medicine and currently serves as the Chair of Infectious Disease here at Mayo Clinic Health System across our southwestern Minnesota region. And in just a bit, Dr. Gomez will be sharing his portion of the presentation entitled COVID-19 Vaccine Myths Debunked. So I briefly previously outlined this. So we're going to start off by having myself talk a little bit about how the COVID-19 vaccine actually works. Dr. Gomez will debunk some of those myths that are flowing out there in social media. I will then share with you the top 10 questions that we're hearing from patients about the vaccine. And then lastly, Mr. Terry Brandt will serve as moderator for a question and answer session. So for those of you that have joined these webinars in the past, we use something called Slido. And you can use any phone, any tablet, any laptop or computer. You go to slido.com. And within the event code box, you would enter MCHS Connect. And there is where you can input your questions that you would like answered. That website is live as we speak, so you can go in now to slido.com, MCHS Connect, and not only input your own questions, but then you can vote up questions by using the thumb up icon to have those questions elevate to the top of the list. So slido.com, MCHS Connect. Lastly, we are in fact recording this webinar today, and we will be posting it for review in the future once we complete the session later today as well. So let's go ahead and get started then and talk first a little bit about how the vaccine works itself, as well as some guiding principles that have been put forward by the Minnesota Department of Health with regards to vaccine distribution. We know that our ultimate goal is that we will in fact receive or acquire herd immunity, whether that's through a combination of natural immunity, which is individuals who acquire the disease itself and become naturally immune, or whether or not we develop immunity through vaccinations. And our goal for herd immunity is to acquire about 75 to 85% of the population to be immune to COVID-19. We think that's the levels needed to, in fact, stop the spread of the pandemic. So that's our ultimate goal. However, we do not have the mass availability of that vaccine at this time. Doses are still being produced by manufacturers. So at the present time, one of our guiding principles is to immunize for impact. What does that mean? Well, that means that currently, vaccine is being distributed by the Department of Health in a way that is designed to maximize the immediate health benefit, to reduce both the death and serious illness, as well as to minimize the harm secondary to COVID-19. In other words, distributing the vaccine to those most in need that will in fact tamper the most negative impacts of the pandemic. The second guiding principle is equitable distribution and access, ensuring that there is nothing from a procedural or structural format that would impact access to the vaccine within the state. And then the third guiding principle is transparency, ensuring that the Department of Health shares information as quickly as possible with Minnesotans with regards to their plan. Now, they have reiterated multiple times that all Minnesotans will have access and the opportunity to be vaccinated. It just may take some time. Also, it's important to realize that the state of Minnesota is not able to control the distribution of vaccine to the state and have very little control over that flow from the COVID-19 vaccine manufacturers. So just a few guiding principles to keep in mind. So how does the vaccine work? Well, what you see on the screen now is actually the coronavirus itself in whole form on the left. And if you cut down the middle of it, a cross section of that virus is there on the right. And you can see the yellow spikes that are protruding from the surface of the virus are referred to as spike proteins. And those play a very important role of the virus attaching to cells within the human body. You can see then within the middle of the virus is something referred to as RNA, and that is surrounded by an envelope. And what the RNA of the virus is essentially that virus's roadmap or its recipe or instructions on how to reproduce itself. And so what the vaccine then has done, it has taken the data from a portion of that RNA, specifically the portion that describes or tells itself how to reproduce the spike protein. And they took that small piece of information within the RNA on how to reproduce that spike protein, and they put that into a vaccine, that into a small molecule that is surrounded by fat molecules, and the fat molecules allow it to bind to human cells. So they place that in a vaccine that is given to individuals. And then what happens is the patient or the individual receiving the vaccine, their immune cells take up and internalize that vaccine, and it tells the cell to begin producing those spike proteins, which it can then do. And the spike proteins then are now released from that cell, and then the body generates its own immune response and develops antibodies towards that spike protein. So that if in the future, as you can see on the bottom right, if an individual becomes infected with the coronavirus, who normally has those spike proteins, the antibodies that were generated from the vaccine block those spike proteins and prevent that virus from reproducing within the human body. Now, importantly, during that second step, when the cell takes up the vaccine, it's an mRNA vaccine. Like I mentioned, it's that roadblock or that recipe as to how to create that spike protein. Once the cell reads the recipe, creates the spike protein, it essentially sends that recipe to the shredder and destroys that mRNA, with that mRNA not ever entering into the core of our cells or the nucleus, which is where our DNA is. So the RNA never comes in contact with human DNA. And in fact, that mRNA is destroyed by the cell once it produces that protein. So that's just a little bit of how the vaccine itself is worked. So I'll turn things over now to Dr. Gomez, who's going to debunk many of the myths that are floating around out there with regards to the vaccine. Dr. Gomez?
Thank you, Dr. Hebl, for the invitation. So we're going to talk a little bit about the most common myth that we have been seeing in social media, and probably a lot of you have questions regarding those myths. Can we get to the next slide? So first myth, the COVID-19 vaccine is not safe because it was rapidly developed and tested. So this is a concern that I've been hearing for a long time regarding how safe is this vaccine if it was just developed within 1 year of actually discovering this virus. So a lot of people have been involved in the development of the two vaccines that we have available now in the United States. And there has been a partnership between private sector, public sector, and academia. And a lot of resources have been invested that have helped in moving this into the fast line of getting a vaccine just about a year after COVID-19 was identified. The fast pace of getting this vaccine was not the safety profile was never compromised. So safety protocols were kept in place throughout the development of this vaccine. And actually, we have thousands of patients that went through the protocol of the two vaccines that we have, and they were monitored for about 2 months after the last injection, looking for potential side effects of the vaccine. Once the studies were completed, the FDA and the Advisory Committee on Immunization, they had a group of experts looking at safeties of this vaccine said they didn't see any major side effects with the vaccine. Now that the vaccine is available, CDC and FDA has actually put in place active surveillance for side effects of this vaccine. So to alert us if there's actually an uncommon side effects that was never identified in the studies, so we can add fast on top of that. So this vaccine, as mentioned by Dr. Hebl, is an mRNA vaccine, and I think that is one of the reasons we went to get this vaccine fast into the public, is because you don't need any production of live cells, any animal products, and it makes the process of creating this vaccine more efficient than compared to other vaccines. So I think that's another component that made this vaccine so readily available just in a few months. Next slide, Dr. Hebl. So another myth, I already had COVID-19 and recover, so I don't need to get a COVID-19 vaccine when it's available. So we know that when people get COVID infection, they will develop what we call natural immunity. So they will develop antibodies to that spike protein that Dr. Hebl mentioned. We just don't know for how long those antibodies will last and for how long that protection will last. We know that in the first 90 days, most likely you will not get reinfected with COVID, but past those 90 days is uncertain. So that's why we recommend that any patient that has COVID-19 infection should actually get the vaccine when it's available for them to take. The next myth, there are severe side effects of the COVID-19 vaccine. And this is false. And this is actually something that I want to emphasize. There were no severe side effects identified in those thousands of patients that went through that protocol of the two vaccines that we have now available. There were local side effects that are common, and those are mainly at the injection site, a little bit of soreness there. And there were some systemic side effects, such as fever, fatigue, headaches. And these are actually indications that your body's responding to the vaccine. And sometimes you will hear scientists mention that they actually like to see that reaction because that means that the body is responding to that vaccine. So no major side effects, very few local side effects, and you have some systemic side effects. So I don't need to wear a mask after I get COVID-19 vaccine. So this is actually a myth. We know that the vaccine is 90% effective in preventing you from getting sick from COVID-19. However, we don't know if that vaccine can prevent from you actually carrying the virus in your nose. And we don't know if it can prevent the transmission of that virus to others. So right now we're recommending for patients to continue to wear a mask, the health, all population, and to continue the social distancing. And also it will take some time to distribute the vaccine to everybody in our community. So that's another fact that we need to take into account. So I just think that the vaccine is another layer of protection on top of the social distancing and the wearing of a mask. More people will die as a result of a negative side effect to COVID-19 vaccine than will actually die from the virus. So this is something that a lot of young adults are actually saying in social media, they are always referencing a 1 to 2% overall mortality of the COVID-19. And I would just like to say that that is the average mortality. But if you look at mortality by age or other medical problems that patients can have, the mortality can be higher in certain group of the population. And this 1 to 2% mortality with COVID-19 is 10 times higher than the mortality of the influenza. So it's not a simple influenza infection like some will want to refer to. And also people are not aware or they don't mention that you can have long-lasting effects on your health after you get COVID-19. So that's something that you need to take into account. So when I look at that and at the potential side effects of the vaccine, I think that the benefit of vaccine outweighs any potential risks that comes with that. The COVID-19 vaccine was developed as a way to control the general population, either through microchip tracking or nanotransducer in our brain. And this is a big myth. I mean, we don't have yet that technology, to be honest. So this vaccine does not have a microchip. There's no way to gather any information or location of patients that receive this vaccine. This came from a comment that Bill Gates from the Gates Foundation made back in March of this year, talking about the digital certificate, which is just trying to get a universal medical record, if you will say. But he never mentioned anything about microchip or introducing any transducer. So that was added to a simple comment that was made at that time. And Bill Gates have not had, to my knowledge, any intervention relationship with the manufacturer or distribution of the vaccine. COVID-19 vaccine will alter my DNA. And I think this was already mentioned by Dr. Hebl on the previous slides of how this vaccine works. So we are actually injecting messenger RNA, which are just instructions for your body to create that spike protein so we can develop immunity against the COVID-19 virus. So this mRNA tends to be quite labile, and after it does its job, it gets destroyed really easily by your body. And it never attaches to your DNA. It never goes to the nucleus where you have your DNA. So there should not be any alteration of your genetic material. The COVID-19 vaccines were developed using fetal tissue. And I think I made reference of that on my first slide. Actually, there's no animal product, no cell cultures, no eggs, nothing related to the development of the vaccine or the manufacture of this vaccine. This was a pure vaccine made in a vitro lab without using any animal product whatsoever. Hand it to you, Dr. Hebl.
Sounds good. Thank you so much, Dr. Gomez. And once again, encourage you to have, if there's any questions out there related to some of those myths, go ahead and submit them to slido.com using the event code MCHSConnect. So I'm going to spend the next 10 or 15 minutes here now talking about some of the top 10 questions that we are hearing from patients. We presume they are throughout our community. So we're going to address these questions kind of up front here, in addition to any tangential or follow-up questions you may have, we can use with slido.com. So question number one is quite frankly that we're getting from patients is, should I be vaccinated? So who should be vaccinated against COVID-19 infection? Well, the answer is everyone. So any individual who qualifies for the vaccine based upon the emergency use authorization, it is recommended by the CDC and the FDA, as well as by Mayo Clinic, that you should in fact proceed with vaccination. Now, how is the vaccine being distributed? Well, it's being distributed to each state from the manufacturers, And then it's the responsibility of the state to prioritize and distribute the vaccine to individual healthcare organizations, hospitals, and clinics. So it's the Minnesota Department of Health, MDH, that is responsible for the distribution of the vaccine. So they have distributed their own plan. It's a phased plan for distribution of the vaccine up until this point. And they have divided the phased approach into several different layers, beginning what they were referring to as phase 1A individuals. So these are the first individuals that have been receiving the vaccine. Individuals within phase 1A includes healthcare workers, emergency medical staff, so paramedics and ambulance drivers, both patients and staff within skilled nursing home facilities, as well as the patients and staff of assisted living facilities. So that is Group 1A. Once all individuals within Group A, or I should say individuals who choose to receive the vaccine within 1A receive it, they will move on as a state to phase 1B. Included within 1B include frontline essential workers who are non-healthcare, which includes our teachers. It includes food and agricultural workers. It includes workers within utilities and public transportation, as well as adults who are 75 years of age or older. Now, within the state of Minnesota, we estimate that there's approximately 1 million Minnesotans within that phase 1B category. Once we are through with 1B, we will progress on to group phase 1C. 1C will include adults who are between the age of 65 and 74, as well as individuals who are between the age of 16 and 64, who also have high-risk medical conditions. Once phase 1A, B, and C are vaccinated, they will move on to phase 2 and subsequently phase 3. And those individual phases have not been defined or prioritized in terms of internal rankings like an A, B, or C. So we cannot state with absolute clarity as to who are involved in that phase 2 and phase 3. We have not yet received that information from the Department of Health. So question 2 then that we're receiving is, when will Mayo Clinic start vaccinating people for COVID-19? Well, we have begun vaccinating our own staff, which are the individuals within that 1A category. So we are only allowed to vaccine as an organization who the Department of Health allows us to vaccine. And we're actually allocated vaccine quantities that match up with the numbers of our 1A workers. So we started that on December 21st. Our own staff were actually subdivided into 7 different waves, with wave 1 being those healthcare workers who are at greatest risk of exposure, who worked with and cared for COVID-19 patients most frequently. And then as you move your way down the various waves, your risk of contracting COVID-19 became less and less. And we made other variables, such as if you worked in the inpatient versus the outpatient setting, whether you had direct patient care responsibilities or you served as support staff personnel, were you acquiring COVID nasal swabs from patients, were you running those laboratory specimens in the lab, or are you non-patient facing staff? And so within our region, our hope is that all of our 1A staff at Mayo Clinic will be immunized for those who choose to receive it by the week of January 25th. More broadly, as a Mayo Clinic organization overall, we think that will likely be achieved by the 1st of February. As an organization, we have also provided the vaccine to non-Mayo Clinic staff who work within our campuses. So other healthcare workers that are non-Mayo employees, we have also offered the vaccine to them and have vaccinated many of them, once again, because they work actively within our campuses. So question number 3 is, what are the side effects of the COVID-19 vaccine? Dr. Gomez touched on this briefly within his remarks, but as he alluded to, the clinical trials have demonstrated first and foremost that the vaccine is safe. That being said, it is associated with minor side effects. We can expect that. And what is occurring is that our body's natural response to the vaccine is working. We are responding to the vaccine, which is in fact producing those side effects. And in fact, those types of side effects are common with any type of vaccine that's currently on the market. How common are they? Well, the localized side effects occur in about 15% of patients. And that includes localized tenderness at the site of injection, perhaps a small degree of swelling, or some redness. And once again, occurs in about 15% of patients. The more broad potential side effects are the systemic ones. And individuals have about a 50% chance of developing one of the following side effects. About a 50% chance of developing fatigue, or a small headache, or muscle pain, or chills, or a low-grade fever, or perhaps joint pain. So once again, 50% likelihood of developing one of those side effects. The severe side effects and reactions that we commonly hear about in the media and social media, yes, they happen, but they happen with any vaccine. And to date, given the about 5 million Americans who have now been vaccinated, these severe reactions are happening in about 5 per 1 million. So once again, an extremely low rate of a severe reaction. Question number 3, how effective is the COVID-19 vaccine? Well, we currently know there's 2 versions of the vaccine on the market. There's the Pfizer BioNTech version as well as the Moderna version. And they are both extremely high reliability and effectiveness. For comparison, the measles vaccine is considered one of the most effective vaccines available and is currently at about 98% effective. We can see the effectiveness of these 2 vaccines are 95 and 94% respectively. Just to give it a little bit of perspective, going into the trials, the FDA had kind of said up front before we knew the results that they were going to accept this as a vaccine if they were in that 65 to 70% effective range. And so you can see the results were very pleasing when we saw it had a much, much higher level of effectiveness, which was great for both of these vaccines. The effectiveness drops just a little bit the older you get. And that's in part because the elderly do not have as robust of an immune system, so you may not generate the same degree of a response as those under the age of 65. So a slight reduction, although not that much, in effectiveness in those over the age of 65. Dosing we'll talk about in just a moment. They are currently authorized, the Pfizer for individuals 16 years of age and older. For the Moderna, 18 years of age and older. And these are the numbers of the individuals who have participated in these trials. 43,000 participants in the Pfizer and 30,000 within the Moderna. So a very large number participated in the clinical trials. What are the contraindications? Who should not receive the vaccine? Well, at present, it includes those individuals who have a severe known allergy to any component of the COVID-19 vaccine, or if they generate a severe allergic reaction to the first dose, and they shouldn't go on and perhaps receive the second dose. Precautions: anyone who has a severe allergy to prior vaccines or any injectable medication should have caution. We still recommend proceeding with the vaccine, but you may have to be monitored for 30 minutes after receiving that vaccine based upon your prior history. And the side effects, once again, I previously talked about. So question number 5, how many doses did the COVID-19 vaccine require? Well, both of the vaccines currently on the market require 2 doses, but they are separated by different time intervals. The Pfizer dose is separated by 3 weeks, and the Moderna vaccine is separated by 4 weeks. So 21 days and 28 days respectively is the time separation between dose number 1 and dose number 2 for the vaccines currently on the market. Question 6, will I have a choice of which vaccine I will get? The short answer is no. At present, individuals do not have the ability to choose which vaccine they wish to receive. At present, the Pfizer vaccine is used primarily within healthcare settings because they have access to the deep freezers that are necessary to store the Pfizer vaccine at extremely cold temperatures. That same degree of cold storage is not necessary for the Moderna vaccine, which is why that vaccine is being allocated and distributed to groups like Walgreens and CVS pharmacies who are owning the immunization of individuals in our nursing home facilities and assisted living facilities. So which vaccine you receive will in part be because of the ability for those storage requirements. But once again, given the very similar clinical profiles, it is recommended that whichever vaccine is offered is the one individuals should proceed with. Question 7 is, how long will a COVID vaccine offer protection? At this time, simply because the clinical trials have only been proceeding for a short period of time, we don't know what the end answer will be. We do know that these vaccines provide protection for at least 3 months because that's the duration of time we have been following individuals within the clinical trials. We know that as time progresses, additional data will be acquired from individuals who have been enrolled in those clinical trials, and we may discover that a more prolonged immunity will develop over time. We simply do not know that at this point in time. We also do not know if a periodic booster will be needed. In other words, similar to the annual flu vaccine. We just don't know that at this point in time on whether periodic boosters, whether it's yearly or every other year, will be necessary. Once again, we'll just need to continue to accumulate additional data based upon the clinical trials and the science available. Question 8, will my primary care provider offer vaccination for COVID-19? And the answer is not at this time. So it's not possible simply to call up your primary care provider and ask to set up an appointment for the vaccine. Your primary care provider does not have access to the vaccine for widespread distribution. So there's no need to contact your physician at this point in time for the vaccine, nor is there a need to contact them and ask to be put on a wait list. As we mentioned, the Department of Health has very laid out in a very clear manner the rollout of this vaccine, and patients will be contacted either by public health officials, the Department of Health, or by their local healthcare provider when they become eligible to receive the vaccine. And at Mayo Clinic, that communication will come through to you using the patient online services, so your patient online portal account. That's how individuals will be communicated as to when, in fact, their turn is up and they are eligible to begin receiving the vaccine. Question 9, can those who have had COVID-19 in the past get vaccinated for it once again? And as Dr. Gomez touched on previously, yes, they may. Individuals who have previously had the infection are eligible to receive the vaccine. However, because they do have that natural immunity for at least 3 months, we do recommend that they wait for 90 days after the date of a positive COVID-19 test. Individuals should not receive the COVID-19 vaccine if they have any active symptoms of COVID-19, whether or not they have had a positive test or not. So symptomatic individuals should put off or delay receiving the vaccine. Also, for those individuals who have previously received either convalescent plasma, if they've been hospitalized with the disease, or if they've received monoclonal antibody therapy, they too will also be asked to wait the 90-day waiting period before receiving the vaccine. Lastly, can pregnant, breastfeeding, or immune-compromised individuals receive the COVID-19 vaccine? And the answer to this is yes. The American College of Obstetricians and Gynecologists actually came out and made a statement on the vaccine and recommends that the COVID-19 vaccine should not be withheld from pregnant or breastfeeding women, but patients are encouraged to contact their healthcare provider for additional information, as well as to discuss the impact of both the safety and the efficacy of the vaccine in either pregnant or breastfeeding women, to talk about the level of the COVID-19 activity within their communities, as well as the potential risk to the mother if they were to acquire the disease and refuse the vaccine, for example. So all those points of discussion individuals should have with their healthcare provider to better understand if the vaccine is right for them. With regards to immune-compromised patients, so these are individuals who have weakened or dampened immune system, whether that's from disease states like HIV, or if individuals are receiving chemotherapy. Those individuals may receive the vaccine. Those types of individuals are not recommended to receive live vaccines, but that is not what COVID-19 vaccine is. It is not a live vaccine, as we've described. So they may receive the vaccine, but the only caveat is it may be less effective. It's unlikely they would receive that same 95% degree of efficacy because they have that blunted immune response. So it's safe to receive it, although they may not receive the same degree of benefit as an individual who does not have a weakened immune system. One last thing I'd like to comment on before we open it up is outpatient infusion therapy that is also available for individuals who test positive for COVID-19. So monoclonal antibody infusions are now available at Mayo Clinic for patients who contract the disease. So this is an infusion, a solution of antibodies that in a similar way to the vaccine have been manufactured and put into an infusion. So who can receive the outpatient infusion therapy? Well, you have to have a positive COVID-19 test. You have to be within the early stages of the disease. So within the first 3 days of a positive test and within the first 10 days of receiving symptoms. You also have to be displaying only mild or moderate symptoms. For example, you have to not have required hospitalization, no oxygen requirements, etc. And currently, age 65 or older, although that number is continuing to decline, we're also considering patients 55 years of age or older. If you choose to proceed with receiving this infusion once you've acquired the disease, it includes a 1-hour infusion here at the Mankato Hospital. And the goal of this infusion is to stop the progression of the disease in its track and to prevent the hospitalization of those who are at highest risk. Mayo Clinic has transfused over 2,000 individuals on an outpatient basis with the monoclonal antibodies. We've had incredibly exceptional outcomes with very, very few of these individuals needing hospitalization. Without this infusion, these individuals would otherwise expect about a 15% or higher risk of needing to go in the hospital. So 1 in 7 to 1 in 5. We've been able to reduce that significantly by about 4-fold. So if you're contacted by a healthcare provider and offered the option of receiving the monoclonal antibody infusion, we'd strongly recommend you consider it and consider proceeding with it, because we do know it restricts, or I should say reduces, your risk of severe disease and hospitalization. So that's what we have for prepared comments. We have about 20 minutes or so now available for questions. We'll turn things over to Mr. Terry Brandt. As a reminder, for questions, go to slido.com and MCHS Connect. Terry, we'll turn things over to you.
Thank you, Dr. Hebl, and good afternoon, everyone. And maybe just a couple of housekeeping items. If you haven't used Slido before, as Dr. Hebl said, please review the questions on the list for that event code. Many times we're seeing duplicate questions. Someone may have already asked your question, and if you click on the thumbs up icon, like Dr. Hebl indicated previously, it will move it dynamically up in the priority, and it will get answered more quickly. So please share that way. Same with some of the Zoom chat features that we're seeing. I think if you flashed, I'd encourage those people to also submit any questions through Slido. So with that, we'll get started. The first question I'll direct to Dr. Gomez. How many days after the second vaccine dose would you consider someone to be protected and have immunity? In other words, how quickly are they protected?
Thank you, Terry. So in the studies, they found early protection even after the first dose. They think after the first 10 to 14 days, there was some protection. And after 7 days of the second dose, they started to see early protection. So I will say probably between that 1 or 2 weeks after the second dose, we should start seeing protection.
Thank you. Next question I'll direct to Dr. Hebl. You covered some fertility questions, Dr. Hebl, but maybe this is a kind of an offshoot of that. Could you clarify whether or not the vaccine can impact fertility? I've seen mixed messages in the media.
Yeah, so that's been a really common question and concern out there. There was some early social media that was generated from that, and it all began with an individual on the East Coast who has known writings in the past on being opposed to vaccinations in general. Bottom line is the clinical trials did not include specifically or known pregnant patients. So the clinical trials did not include that. That being said, there are hundreds of, or tens, if not hundreds of thousands of women who have acquired the disease over the past 12 months who have been pregnant. And they themselves are developing that natural immunity because of exposure to the disease. They have not seen higher rates of miscarriage. They have not seen higher rates of inability to become pregnant. So it is not believed that the vaccine does in fact impact fertility, whether it's your ability to achieve pregnancy or higher risks of miscarriages. Once again, the American College of Obstetricians and Gynecologists recommends proceeding, but for additional information, you should contact your local providers.
Thank you. The next question, I think you already addressed, Dr. Hebl, about the need for boosters, or I guess it was Dr. Gomez, in 1 to 5 years from now. We don't know yet. It's simply not known yet. So that's the response on the boosters. Dr. Gomez, we are hearing about another strain of the coronavirus that is even more contagious. Will these vaccines that we've talked about today also provide immunity against this strain?
Yeah, this is a common question actually amongst providers and experts. They are working on getting that answer, and I was reading that we were supposed to get that information this week. I have not read yet those results, but in general, the scientists are optimistic that this vaccine should cover that, because you have just a handful of mutations or changes in that spike protein that maybe are overcome by different type of antibodies against that same spike protein. So we don't know yet. We're optimistic that it will be effective, but we should have some more information in the upcoming weeks.
Yeah. Dr. Hebl, anything that you'd add to that response?
No.
Thank you. The next question. I think I know the answer to this, Dr. Gomez, but I'll pose it. Survivors of COVID have temporary immunity, but should still be vaccinated based on our recommendations. How do we know that the vaccine will last any longer than natural immunity? Could you comment, please?
Yes, so that is a question that we don't know that answer specifically, but what I can tell you, if we go back to other diseases, for example, mumps, you can get the infection and you can lose that immunity. However, if you get the vaccine against mump, you can get a stronger immunity that lasts longer than the natural immunity. So we have that as a baseline. There were some studies showing the amount of antibody produced with natural immunity and the amount of antibodies produced with the vaccine. And we saw higher amount of antibodies produced with the vaccine. These are just some anecdotes. I don't have an answer because we have not looked into that. But I will suggest just to get the vaccine at this point until we get more information regarding this topic.
Thank you. Dr. Hebl, the next question, I think, addresses some of the distribution questions. The question is, initially, at least one vaccine was given in 2 doses. I recently read a suggestion to hold off on the second dose due to a shortage. Is this happening, and what are the implications?
So that question may have derived from in the UK, across the pond. They are contemplating not giving 2 doses, but trying to get more individuals vaccinated with at least 1 dose. And that is a situation in which they're considering that because they have many more individuals who want to become vaccinated than they have supply within the UK. The problem with that is after a single dose, we know that your effectiveness for immunity is about 50%, 50 to 52%. And that nearly doubles to that 95% number after the second dose. The other factor is the clinical trials that have been done did not use that format of dosing. So it's just hard to say we're going to have the same degree of protection after the single dose because that's not what the clinical trials evaluated. So at least in the US, the current thinking is from the FDA and the CDC is that we continue with the sequencing that was done within the clinical trials. And at this point in time, over the course of 2021, we do think we will have enough vaccine to vaccinate those in the US that choose or would like to become vaccinated. So we don't think the supply and demand issue will bear out throughout the course of the year. So at this point in time, at least the last I've heard is that the plan is to continue with the 2-dose regimen.
Okay, good. Thank you. Dr. Gomez, why haven't mRNA vaccines been used up until now, despite 30 years of researching them?
So they have been evaluated on multiple diseases like Zika virus. So it was just the timing of getting a product into the community. That's why we made this vaccine ready available within 1 year. When you are looking into bringing a vaccine to the public, it takes a lot of resources and investments, and it takes time because you want to do a phase 1, which is just testing it and see if it works, and then you wait for several weeks. There's a lot of paperwork. So we never had the opportunity to bring the vaccine to the public, but there have been studies about using this technology for vaccination. It's just that they didn't have the time to bring that into the population. We do have a lot of information regarding mRNA vaccination. So I think this vaccine and some others are concerned about additive or adjuvants. This is a vaccine that doesn't have any adjuvants, any additives. So it's a pure mRNA vaccine. So I think this should be quite appealing to a lot of people. In general, I think it's a very safe vaccine, and I do have hope that a lot of people will accept this vaccine.
The only thing I would add, Terry, is there are currently clinical trials going on as we speak with mRNA vaccines for influenza, for the Zika, for rabies, as well as for HIV. And so there are active clinical trials around the country, around the world happening as we speak for those as well. In addition, that same mRNA technology is used in cancer care for delivering various chemotherapeutic regimens and therapies. And so the mRNA concept is not new and is used elsewhere within medicine as well.
Thank you both. We had a question about pregnant women, but I think we've addressed that topic pretty well. The next question, Dr. Hebl, what strategies are in place to reach out to ethnic minority communities who have multiple barriers such as education, language, or culture? How would you respond to that?
Yeah, that's a great question. So as part of the Minnesota Department of Health's distribution plan, and because we know ethnic minorities are at higher risk of the consequences of COVID, they are using as part of their modeling in terms of distributing it to communities and populations that have higher levels of ethnic minorities. And so part of the distribution plan of MDH, that is being taken into consideration, and communities with higher percentages of those disadvantaged from a genetic component and their reaction to the disease state will have higher allocations of the vaccine in an effort to address just what you mentioned and to once again immunize for impact. And so that variable is being looked at very seriously and integrated into the allocation models.
Thank you, Dr. Hebl. That is an important question. The next question, maybe I'll start with Dr. Gomez, and maybe Dr. Hebl knows as well, but the question is, I have heard that Johnson & Johnson is coming out with a 1-dose vaccine. Is this true, Dr. Gomez?
Yeah, they're working on that. They're entering the third phase of that vaccine. So we're looking at that. That's with Janssen. So we're optimistic that that will be another vaccine that we can use to get everybody vaccinated. So we're looking at that data.
Good. Anything to add, Dr. Hebl?
Yeah, not really. I mean, that is true. They are developing a single vaccine, but we just haven't seen any of the data yet. So we have no idea about effectiveness, et cetera. So we'll just have to wait and see what happens as the data becomes available over the coming weeks and months.
Good. Okay, I see we have just under 10 minutes left, and we have the Slido.com questions that we're using the event code, MCHS Connect, and we're still getting a lot of questions, so we'll continue on. Dr. Hebl, what are good resources to give to family and friends that include layperson's terms to educate on the development and the makeup and the myths, et cetera, that you helped address earlier in the talk?
Yeah, so many healthcare organizations, as well as the Department of Health and including Mayo Clinic, are coming up with materials that will be available. So we're developing kind of an education and communication strategy that we will not only obviously provide access for our patients, but provide more broadly to the communities in which we serve. We'll be working with public health partners and with chambers of commerce from across the state. So both on multiple fronts, whether it's Department of Health, Mayo Clinic, or other healthcare organizations, are generating that educational material for a very forward-facing, public-facing communication campaign. So you'll be seeing much more of that in the coming days and weeks.
Yeah, and I think, Dr. Hebl, we've seen some feedback. This seminar this afternoon will be available on some of the Mayo sites as well to share with people. We've seen comments about that as well. The next question, Dr. Hebl, you've addressed this, and it's on everyone's mind. When will the vaccine be open to the general public? We really don't know. We don't have a crystal ball like that, and it's not under our jurisdiction in any event.
Yeah, it's hard to predict. If I had the crystal ball, I would love to give someone, the individual, the answer to that. But what we do know is that the next group of individuals is that phase 1B. And that's about 1 million individuals. And we think we'll likely be starting phase 1B in early February. We'll have to vaccinate about 1 million folks within that group before we move on to the next phase. At least that's the current plan by the Department of Health. When will it be available to the general public? It's hard to assess, but I think, late spring, potentially early summer. It's just so hard to predict at this point in time. The faster we get the distribution process up and going from the Department of Health and the state, the more quickly we can get to all individuals in the state who wish to receive the vaccine.
Yeah. Thank you. Dr. Gomez, the next question is, I have heard that the second dose to the vaccine may have worse side effects than the first. Is this really true?
So what we saw in the clinical trials that they were more frequent. So you could get the first vaccine and not have side effects, and then have side effects with the second vaccine. And that is just because you were primed. Your immunity was primed during the first vaccine. So we think that you will then react a little bit more frequently during the second vaccine. But overall, there were no significant side effects. They were all mild to moderate. And I think that's what people need to understand.
Okay, good. Thank you. Dr. Gomez, the next question. Forbes had an article about a connection between the vaccine and Bell's palsy. Is this a legitimate concern, one way or the other?
So this was reported actually in the Pfizer trial and in the Moderna trial. We saw Bell's palsy in the group of patients that received the vaccine, and not so much in the placebo group, or people who did not receive the vaccine. Based on the discussion of the experts, they think that this was not related to the vaccine. They think that it occurred in the same frequency that will occur in the general population. So Bell's palsy, we see that in the general population, not related to any vaccination. However, they will be following patients that receive the vaccine or any reports of Bell's palsy, and we should get any feedback if there's actually an association. But it was decided based on that group of experts that evaluated the data that this could just happen randomly because it's common to have Bell's palsy in not related to the vaccine.
Okay, thank you. Dr. Hebl, this is a distribution question. I don't know if we know, but I'll ask. And there's 4 people that voted it up, so there's interest. I am a Snowbird, presently residing in Arizona, lucky soul. However, my residence is in Minnesota. Will I be able to get vaccinated here in Arizona? Do you know the answer by chance?
No. We could speculate because we've heard bits and pieces. We think, once again, the distribution of the vaccine is up to each state, and we expect to be a multitude of different answers. So Arizona may do some things differently than Texas, that may do things differently than Florida. Some states we have heard will vaccinate anyone that is currently there and living there. Others we have heard are going to refer them to where their state of primary residence. So it's at the discretion of each individual state. So you'll have to check with your local public health officials, wherever that may be, Arizona or otherwise, as to what or how they plan on approaching the situation.
Okay, good. Thank you. Next question, Dr. Gomez. It's related to some of the allergy questions, but I have heard that someone who has a severe allergy that must carry an EpiPen with them should not take the vaccine. Is this true? How would you respond to that?
No, we're still advocating for the vaccination. What we are doing is just observing patients for a longer period of time after the vaccination to make sure that they don't have a reaction. There's still discussions about what is driving this allergy, and we'll probably have more guidance in the next several weeks. But right now, the only contraindication is if you had a reaction to the first dose of the vaccine. So that will exclude you from getting then the second dose. But all the other allergies, we are just being more careful, monitoring for any potential reactions after the injection.
I would just add, or a known severe allergy to one of the ingredients of the vaccine.
Correct, yes.
Okay, all right. Dr. Hebl, I see we're about at time. We still have questions, but would you want to close us out and summarize what we've talked about today?
Sure. Just first like to thank everyone for joining us today. We will likely have additional webinars over the coming weeks and months as this process continues to unfold. You can also look forward to receiving additional educational material and resources, whether it's from Mayo Clinic or the Department of Health, more broadly within our communities. And we'll use a variety of different mechanisms to get those out to the communities in which we serve. But this is an ongoing, evolving issue in terms of how the vaccine will be distributed. We too are waiting to hear additional word from the Department of Health on what future plans will be. So once we get those, we'll be sure to communicate them with you as well. So thanks again for joining us today, and look forward to touching base with each of you and connecting with each of you again at a future webinar. Thanks again for joining us, and have a great day.